start the session. Okay, we're going to start this session. So thank you to everyone for joining us. My name is Sarah, and I'm an SPR in rheumatology, and will be moderating this interview preparation session with Mustafa, who of course needs no introduction. We have an absolutely brilliant lineup of speakers today, very experienced consultants and senior doctors, and indeed a new BST trainee as well. So I have some ground rules that I'd like to go through before we kickstart this session. If everyone could please keep themselves on mute. If you have any questions during the session, please ask in the chat and we will address them as we go along. And just so everyone knows, this session is being recorded. At the end, we'll also have a live Q&A as well, so you'll have a chance to ask questions at that point also. So I don't think we need to speak about what the BST is. I think everyone that is joining us today has an upcoming interview. So firstly, congratulations on securing that. The interviews are starting in a few days, so I think we'll just go ahead and kickstart. So I gave my own BST interview about 5 years ago, and I don't think an awful lot has changed since then. Our first speaker is someone who gave the BST interview last year and was successful. We've been joined by Dr. Lucy McCourt, who's very kindly joined us after her after call today. So Lucy, whenever you're ready, I'm happy for you to take over and speak about your experience with the recent BST interview. You can talk to us about the questions you were asked, how you prepared, what you found useful, if there are any resources that you would recommend or advise, what you would do different if you had the chance to do it again. So whenever you're ready, Lucy, you can go ahead and talk to us about your experience.
Lucy, just before you go ahead, just for all the participants, if you have any burning questions while Lucy is speaking, or any of the speakers, any of the panelists are speaking, please ask it on the chat. We'll open the room for Q&A session at the end, so you can speak out your questions at that point. But up until then, please mention all your questions in the chat box. The chat box will be monitored. Also, some of you have Dr. M, AM, names like this. I'd appreciate if all of you can put your names up, just for ease of convenience of us knowing who's asking the questions. Thank you very much. Lucy, the floor is all yours.
Hi, everyone. Thanks very much, first of all, to Dr. Anwar and Dr. Sarah for asking me to speak today. Just a heads up, it's very short notice, and I'm just going to kind of talk freely as to my experience, if that's okay. And any questions, more than happy to talk through them. So I'm first year BST. I suppose the way my career has gone so far, I did grad med in UCD in Dublin, and then I did intern year here in Dublin and went to Australia for 2 years. So I did my BST interview last year while I was in Perth in Australia, and came back then and started in July. So I did 6 months in the Mater Hospital in Dublin, and now I'm just finished the first week here in Navan, in Our Lady's Hospital in Navan. So I, first of all, like has already been said, well done to everyone getting an interview. It's a daunting time, I know. It's the first real interview you've probably done in medicine. And there's a number of ways to going about doing it. I suppose I started off by asking those ahead of me what they'd been asked to try and gather information. And what I seemed to obtain was that there's 4 main questions asked over 15 minutes. It's really short. The interview goes really quickly. There are two kind of clinical / ethical questions. So 1 clinical case, 1 ethical case, and then 2 questions that are more about you or about your career so far. So what I found was that the interview started very abruptly and we went straight into questions. There was no question asked about me or like my career or anything like that. So just to be ready for that, my advice would be, set up your place very early and make sure your housemates know you're doing an interview, put a note on the door, anything like that. And just so you're not flustered when you're going in. My questions, just to give you an idea. So my first question was that you were working in an outpatient setting as an SHO, and that somebody came in, a man in his 60s came in with a background of ischemic heart disease, and mentioned that he'd had a collapse on the way into clinic. So I suppose going back to basics, what everyone is trying to make sure that you're going to do is that you'd be safe in working as an SHO on call, say, or working in an ED department, and that you'd know when to escalate to senior help, would be my understanding. So I would have said, starting at the start, I would have, done an ABCDE assessment and made sure that the patient was vitally stable, get a repeat set of vitals by the nursing staff if they're there. Don't ever forget glucose in that case. To be honest, I don't think I said that he would need admission, but I think in hindsight, I would have said, I think he should have been referred to ED for monitoring at least for a few hours and then sent home and had troponin and different things. So that's just me looking back. I probably could have improved on that, but that was one example, and a few other people had similar ones. The second question I had then was about a lady in her 80s who had a stable upper GI bleed, needed an endoscopy, but was refusing it and wanted to go home. And she said, all her friends were dead and she just wanted to go home. So I took this as sort of a capacity assessment and whether she had it or not. And then if she did, that it would be fair enough if it was stable and she was stable, that she could go home. So I definitely mentioned in that one that I would have consulted a senior just to confirm that that was fine. And I would have done the same in the first case as well. But just to kind of double check again, ABCDE, check her bloods, check her vitals, make sure that she is stable. And then go through the capacity assessment with her. That may have changed slightly, but in general, it was, I was asking, was she able to understand and retain and repeat back to me any information I told her, and understood the risks and benefits of staying in hospital. And then if I felt that if she did have capacity, once I'd discussed with the senior, then that would have been fine for her to go. But yeah, that was a tricky ethical one. Another one I've heard of in that type of category is a bus driver who comes in, sounds like he's had a seizure and then wants to go home. And you have to obviously acknowledge there, well, what's the risk of him going home, his occupation? So I think you can speak logically through it out loud and saying, well, the risks of them going home in this context, it's worth just verbalizing that, I think, because showing that you're thinking through it. And then the two other questions I got were about, the first one was about what options you can do after the BST. So I actually can't remember. I don't think I really prepared that one, but I suppose the obvious one is you can go on to into a specialty, like Sarah has gone into rheumatology, and do the specialist training. Or you might choose to go to something else like GP or radiology or something else, or do some academic work. So just have a bit of a system as to what you're going to answer for that if you get asked, because it's an easy one to do well in, I would say. And the other question was about what I thought the value of research was in medicine. And I mentioned something about commitment to lifelong learning, and that, we practice evidence-based medicine. So it's useful, I find, these are words that are easy to say, but if you have a think about those sort of questions before you go in and jot down a few phrases that are they're kind of hitting key words, I think that would be useful to do. There's a good resource that a few of us used called, I think it's ISC medical guide, like interview something guide. It's a long PDF, but there's a few good kind of scenarios they talk through, because I know one of the other kind of things to prep for, and I don't know that people get asked this, but we all prepped for it, would be when people ask you to describe a scenario where you did something. So a scenario where you were a good leader, a scenario where you had a challenging patient, a scenario where you appropriately called for help. I think if you wrote down, even if you could even come up with 5 cases, if you pick even one case where there's a few skills demonstrated that you can think of from previous work, say an example where you called for help because you were out of your depth and that was the right thing to do, or someone was busy and MedReg was busy and you had to take the lead on something. If there's one case, because you will be nervous, I think it's good to have one case that you can rely on and go back to. So have a think back through your placement, even any work you've done so far, and just think, okay, what does that show for me? What is that a good example to show about me? And the other prep I did, so that's kind of basic interview prep. And the other thing I did was just wrote down a list of kind of common on-call emergencies that you would get called to. Like syncope was one of them, or something that might come in to ED as an SHO, and just to make sure you had a brief idea as to how you'd manage them. Some people I know got asked, more common ED presentations, like and management on the ward, like management or workup of someone with anemia. How would you manage that? Or, but you'll know that sort of thing. I think just try and have a systematic approach. And number one is making sure the patient is safe, and that even if you don't know, that you know who to ask. And I think what they're looking at is to see would you be able to be a competent SHO. The difference between being an SHO and intern really is admitting people from the ED, and that's really it mainly. And so being called to review people. So that's kind of my overall thinking out loud. I know later on in the talk, people are going to talk through what they'd say they would think would be good answers to some of the cases. So that will probably give you exactly what they actually would like from a marking scheme point of view. But I would say always go back to basics, A, B, C, D, E, and just making sure you're looking out for red flags and the patient is deteriorating. And I know someone has just asked there about the guidelines. I'm just going to go into my email and get it up for you. It's the ISC Interview Skills Consulting Medical Group, and there's a guide that's what we used. And yeah, it's basic interview prep, which a lot of us hadn't done before. So yeah, that's kind of it. Anything else anyone would like to ask or like me to add?
That was actually very useful, Lucy, to go through. And I think I did my BST interview about 5 years ago, and I think it's interesting that very little has changed. So I was also asked that question on being the cardiology SHO in clinic and having a potentially unstable patient in what is usually assumed to be quite stable. So we're going to have our consultant cardiologist answer that question for us, and what he would like to hear, and the kind of key points that interviewers should be hitting on. And same with the ethical scenario. Capacity is something that comes up time and time again, especially in the aging population that we have in Ireland. So they're both very commonly asked questions, and I think questions that should be prepared well in advance. In terms of preparation, Lucy, how did you practice interviewing with colleagues, or do you think maybe
so I think I was asking some friends today just for feedback, and the bottom line is practicing saying stuff out loud, because it is really daunting, and even practicing talking to your computer, because I don't know if it's still on Zoom, I think it is, but it's really hard to actually look at the camera in your computer to try and make eye contact with the people. You kind of tend to look up into the sides, and it's just giving a good impression. And I really think a little goes a long way in terms of being yourself and smiling and good eye contact. I think that's actually really valuable, because ultimately people want to make sure that you'd be nice to work with, and well, that's my impression. So I think like practicing answering questions looking directly at your computer is something you've probably never done, so I think that's worth it. Talking through with friends, like I was, as the interviews were starting, we were hearing what people were getting asked as the days went on, and I would talk to my housemates at the time and say, what would you have said for this? And maybe something I had never thought of, they would mention. And obviously everyone has slightly different answers, but it's really useful, because as you say it out loud, you think, oh, actually, I probably wouldn't do that, or in fact, that patient, like Sarah has said, has the potential, like potentially they've had a cardiac event on the way into clinic and are on the brink of being quite unstable. So this might warrant, letting a senior know, actually alerting someone, because they've just arrived in clinic and they're sitting in a pile with other people. So yeah, definitely just practicing out loud, and logically thinking, okay, 3 reasons for this, A, B, C, D, E, just showing that you're kind of logical, I think goes a long way. But I really think smiling and being friendly, and that also very important in an interview.
No, I totally agree with that. And I think like when I gave my interview, it was in person, and it is trickier on Zoom to engage a person. So I think they're looking for those things even more so possibly. That's a big part of the interview, and our colleague Dr. Samreen Park will be talking about that as well in more detail. I didn't know about that resource actually, so I think if people are still looking for resources, then to definitely check out the one that you mentioned there. Lucy might even get you to type that out actually in the chat, so if anyone joins us late, they can see it.
Sure. I can send it to you,
I've just
Sarah.
shared
Well,
the link to the company that runs those courses. It's on the group chat.
brilliant.
Great, perfect.
And
Okay.
I can send you. I have a list as well, Sarah, of questions that people came up with from last year. If you'd like, I can send them to you now. And you can send them in. Or I can screen send it in. It's just common ones to think about. Like I'm looking at them here. Like newly diagnosed AFib in an alcoholic with CKD, not keen to take warfarin, discuss. You know, those kind of medical ones that are. I'm literally just looking at a list now. But if you'd like, I can send you them because they get.
That would be perfect.
Yeah, I can send that in now if you'd like. I can take a screenshot and send it in. Yeah,
Okay,
I'll do
brilliant.
that.
I think that's actually that's a tricky one, and I think I want to focus on something you said earlier, that you are allowed to speak, talk through your process. I don't think they want a perfectly worded answer. They want to see what your thinking is. So absolutely, you know, if you get a question that throws you off, start from scratch and tell them what you're thinking and talk through what you're thinking, because I'm my own impression of the interviews, that's what they're assessing. They're not actually looking for the right answer. They just want to see are you able to think through something logically. So do definitely verbalize that, especially in the trickier questions.
Yeah, I'm just going to send that in now to the group chat, guys. So hopefully that provides a bit of help. BST questions 22 and 21. Yeah, they're gone in there.
Brilliant. Thanks very much, Lucy.
No problem. I hope that's been helpful.
Brilliant. Thanks so much again for joining us. You're very good because I know you're on call. So thanks again. And if anyone has any questions specifically for Lucy, we can ask at the end. Perfect, Lucy. So thanks very much again. We'll move to our next speaker.
Okay.
So Dr. Samreen Tariq is a rheumatology fellow. Our panelists are quite rheumatology heavy today. But Dr. Samreen Tariq is going to speak to us about general interview tips and tricks as well. So, of course, the sessions interviews have changed dramatically over the last number of years. More and more interviews are being held over Zoom, and it's a different dynamic. Like Lucy mentioned, most of us, for a lot of the BST applicants, this might be the first interview they're giving over Zoom, and it's a different environment, and it takes a while to get used to the setup as well. So, Dr. Tariq, whenever you're ready, to go ahead and speak a little bit about interviews over Zoom.
Hello, thank you, Sarah. Thank you for having me. Good evening, everyone. My name is Samreen. I'm one of the rheumatology SPRs, currently working as a rheumatology fellow in the Mater Hospital. Congratulations and well done to all of you who have secured the interview. I did my BST interview almost 8 years ago, so definitely not much has changed, but over time it was face-to-face. I'm aware that this time it's going to be through Zoom. So I'll quickly go through some general tips for the online interview, and then we'll touch base and discuss some BST-GIM scoring guidelines, which I was just told at the nick of the time. So we'll try to summarize that. First of all, interview can be a daunting and a nerve-wracking process, even for the seasoned professionals, but a good prep can definitely reduce your anxiety or stress levels. So the prep session, I'll just divide it into 3 bullet points. Prep your device. Number 2, prep the environment and the background. And obviously, prep yourself. First, setting up the device. Preferably log in through a laptop because of a better connectivity, and familiarize yourself with Zoom. So ideally have it downloaded. Obviously, you are all linked in through Zoom. Check in your microphone, headset, your sound system, your connectivity well in advance of the interview. Have it all prepped. Your device should be prepped before the interview. Make sure you mute all the notifications and your software is fully updated. So just to avoid any distractions during the interview process. Then prepping up the environment, choose a quiet room, which is well lit. As Lucy said, tell your housemates, everyone who's living in the house, that you have an interview coming up so that the distractions are minimized. Your background should be plain and simple, again, just to avoid it being very overwhelming, and the focus is more on yourself rather than anything else in the background. Connectivity is very important. Choose a room where you have a very good Wi-Fi connection. Ideally, check it closed door 24 hours in advance. Check your internet connection. Make sure that that room has a good Wi-Fi connection. And in the end, prepping yourself. Dress professionally, even if it is not a face-to-face interview. Just dress up as if you're going for a face-to-face interview, a formal suiting and pant or a skirt and a formal coat. Go for muted colors just to look more professional, because that is going to be your first impression. So make sure you work on that as well. Your body language is very important. Come across very confident and wear a smile. That would definitely help. Being a good listener is important. So listen to your question, listen to the questions that are asked carefully, and then obviously have a thought process the answers, and come back with the answers. Some general advice: log in at least 10 to 15 minutes before the interview starts, and look into the camera. As Lucy said, it can be difficult, but try, like having mock interviews beforehand definitely can help. So maybe do some mock interviews and try to look into the camera as you're speaking rather than onto the screen. Because when you're going for face-to-face interviews, eye contact is very important. And you'll have to work on that when you're going for a virtual interview. So these are some basic and general tips when you're going for an online interview. If you have any questions regarding this, I can answer now, or I'm happy to jump on to the next section of scoring guidelines for the...
So I think, again, what Samreen said about treating this like a face-to-face, so dressing very professionally, dress for the job that you want, not the job that you have. So it's a similar approach with this. And again, only a certain small part of you seen on screen, but even having yourself wear a suit, a nice dress shirt, a tie, it goes a long way, and it's definitely noticed, and smiling goes a long way as well. I think it's important to look like you're enjoying the process as opposed to being tortured. I know after I gave my HST interview, my mouth was sore from smiling so much. So I think they really noticed this, and I had a lot of my interviewers ask me afterwards, oh, have you given lots of interviews? Do you enjoy giving interviews? So I was asked if I enjoyed giving interviews, and of course the answer is no. But I think it's important to try and at least look like you're not being tortured.
And it also shows that you are interested in the job that you're applying for. So definitely goes a long way.
It instills confidence. So definitely to pay attention to how you dress, and again, smile and look like you're not being tortured. Okay, you can go ahead, Samrina, maybe go through the interview breakdown. I think most of the candidates that are sitting the interview should be hopefully very familiar with this, but we'll go over it again.
All right, so the interview scoring guidelines, they are available actually on the RCPI website. The breakdown of individual section is not very clearly available on the RCPI website. I had to go through BST Pediatrics section to get some of the breakdown of the undergraduate achievement. But we can share that in the online group or through email later on. But total marks available are 100, and they are then subdivided into 3 categories. First is academic achievement, for which there would be 40 marks max. And in the academic achievements, there are further 3 subdivisions. First is your undergrad academic achievement, which contributes almost 20 marks out of those 40. And then research and other qualifications make up to 13 marks max out of that 40. And professional development contribute at 7 marks in total. The second division is clinical insight, where you will be asked clinical scenarios. And I think Lucy did explain all that in detail, but there would be maximum 34 marks out of 100 allocated to that. And then the interview performance and the communication skills in general, they hold 26 marks out of 100. So definitely very important. So academic achievements, I was discussing this with Sarah earlier. The undergrad academic achievement, which is making the major chunk of almost 20 marks out of the 40. Those who have graduated here would know the centile process, and I can share a screenshot later on in the WhatsApp group where they have allocated top 10% for 90 to 100% contribute as 10 marks towards this, and then so on and so forth. Next 20% contribute to 8, and then 6, and then 4. We'll share this as in the WhatsApp group, but this is the sub division of the undergrad academic achievements based on the centiles. Now in Pakistan, obviously, we're not given the centile scoring, and your final year marks are more contributed towards your final assessment. But I'm not entirely sure, but 4th and 5th year marks are probably more contributed as centile towards the Irish graduate system, isn't it, Sarah? Correct me if I'm wrong.
No, that's correct. So here, 4th year and final year goes towards your final grade. So your centile is based on the 2 years.
Yeah, so I think this centile system, you might have to contact your university and get it get the equivalence as per the centile system. Then the next is research and other qualifications, which contributes 13 marks out of the 40. And if, again, I will share the screenshot. It is available on the RCPI website, and they've nicely subdivided it as if you are PhD, you would be granted 4 marks. If you are a first author of an article in an international journal, you would be granted 4 marks, and so on and so forth. There are markings relative to oral presentations and posters presented at national and international meetings, and all of them have respective marking. So we'll share this in the screenshot just for clarification. And the last one is professional development, which is just the postgrad exams that you have passed, teaching experience that you've had, anything that you've done after graduating. And on the NDTP website, there is a resource regarding professional development scheme where they've given link to prospectus for the NCHDs for the non-training, who are not on training. And I can share the link with all of you as well. So this is really it. And I hope that this was helpful.
That's great, Samreen. Thanks for going through that. So from, again, all the feedback I've received with people that have recently given the BST interview, it seems that we're not actually asking that question as often anymore. Talk us through your CV or tell us a little bit about yourself. It doesn't mean that you shouldn't prepare this. This is a question that you should know, you should be able to answer inside out in your sleep. But what we're going to do now is we're going to move on to the medical emergencies. And again, like I mentioned earlier, I think the focus of the BST interviews to assess or look at what your approach to a sick patient is and what your thinking process is. So the next speaker I'm going to invite is Dr. Rahim Khan, who's a consultant gastroenterologist. So Dr. Khan, if you can tell us, how would you approach a general medical emergency? We're not going to go through every emergency that may be asked, but if you give us your general approach or what you would like to hear in an answer, if you were to sit on a panel, and then we'll ask you more specifically as well how you'd answer or how you would approach an unstable upper GI bleed. But if you initially start off by talking us through what you would like to hear when addressing the medical emergency question.
Yeah, no problem. Hi, thanks very much for inviting me to this meeting. We have been so busy in the clinical life. I'm thrilled and really enjoying this academic discussion today, because life can get busy and then you kind of miss your academic side sometime. I'm sure many people know that went through their training in HST. It's a very rigorous process. I'm just gonna give just one general advice. There's a lot of advices everyone has, and they're all valuable. And I'll come to the medical emergency in a minute. But I think I found something really, really useful. So interview preparation, few bullet points, big ones. Do not take it for granted. Do not think that it's something I can just sit down, write down, and don't do anything practically about it. I think a formal approach should be applied. If you take it formally, I think you will do better. So how do you take it formally? How you do it? No, everything else that you need to do, you need to do them. But I think taking it seriously, the easy way to do it, I will just mention is record yourself in a video. So put out a camera and record a video of you talking about your CV. Just very simple, first question. And I can tell you now, you write down this sentence with you, you will find 10 different problems by listening to you talking to your own camera, and then work on that. So, I mean, the question, okay, so that's one point. So formal preparation is important. Talk and record and make out the mistakes, even if it's fluency, the flow of your talks, because you don't want to look like you're making up stuff. You need to be fluent and you need to be nonstop about a question. It should come from inside out to the interviewer to say that I think this is a genuine, this is a genuine process that you have gotten through or worked through, and which is genuine, but we're not able to express. So the expression is important. The other thing is, I think the questions are out. So it's not a paper where we don't know the questions. This is a very easy part of it. So we know, I've just calculated, I think there is 6 questions in a medical interview, BST or HST. So we focus on BST. One is a CV, go through your CV. 2 is your clinical experience. 3rd is your academic experience. 4th is your research and audit. 5th is your clinical case or ethical dilemma, which they will give you. So you need to prepare. I think the way to tackle that clinical dilemma, okay, if they give you a medical case, you probably will do better. But if they give you an ethical one, it can be tough. So the book that was mentioned, the interviewer book, the UK one, is very helpful. They have hundreds of it. But if you prepare the first 20 or the most common 20, I think there's a high chance you get one of them, and then you're sorted. And then so yeah, so now we're coming to medical emergencies. So the questions are out. I think more you need to think those 6 points, how you're going to cover them, how you're going to prepare for them, each and every single one. And then you will probably be ready for interview. Because we have a lot of experience in clinical. So we go to hospital in the morning and come back at night. This is the most common scenario. But you haven't gone sit in a class as a student anywhere during your work. Very rarely you will go to a university where you're a student, but you're also a doctor at the same time on a BST or SHO. That will make a difference in the academic, where Samreen mentioned 40 marks. So we are lacking in that part. So if you can present a certificate or a diploma or a master degree or some sort of attachment to that, you will gain an extra marks. And it's not common. So if there's 10 people coming to the interview, I can tell you there will be 3 or 2 that will have done such certificate or so there's 8 or 7 highly likely that they haven't done that. So you've gone those marks again, and you're ahead in the game. Okay, so I think this is just a general advice, but I think medical emergencies was my topic. So if you are called for a medical emergency as a junior doctor or SHO, the first and the most important thing is, I think you need not to forget your limits. Like, you need to think what you can do and what you can't do. And what you can't do, and then your port of call is important. So it's not that you keep calling from the start. but you need to be aware what is your backup plan in case there is something that you don't know or you can't do, and to activate that in a timely manner. The other thing is, most importantly, when you attend, make sure you leave everything else. If you think this is a serious emergency, you should be there straight away. Do not put it off, because that will make a very bad impression to your consultant and to the team and ward and nurses, everyone. And the patient can get worse or die. Really bad situation. So attend in time and know your limits. And then the other thing is, the most important thing, when you're on the scene, I think you should know the depth of sickness. So I mean the level of sickness. Is this a ward level manageable? Can you manage it with medications? Is something really small, but the nurses just made a serious call out of it, which can commonly happen on the wards. When you go there, there's a tachycardia of 130, but when you go, it may be 105 or 110, and you're kind of comfortable to say, I think that's not too bad. I think I can work out to see how I can help. So know the clinical sickness level, or this is an ICU level. Is there an organ failure here, respiratory failure, or there's a renal failure that needs an urgent attention, or any failure, or decreased GCS. So I think assessing what level of care this patient will require is important. But then again, it depends on what exactly the illness is. So then you need to start making your plan how to treat that illness in that scenario. So if you do these things right, I think you will do better, because everybody knows that you're you at your own level, SHO or a junior doctor. They don't expect any high level of contribution to the case or any heroics or anything, but they expect the basic things that you know, and you make the right decision at the right time. It can be a collapse cause, or myocardial infarction, or a pulmonary embolism, or a GI bleed. So it depends on the case. Then you can start treating those cases. So I think my case was.
Yes, so we're going to reverse roles,
Yeah.
and I'm going to
sure,
ask you a question that I'd like you to answer. So I think what you said was important, that there's a general approach, and most of the marks are actually going for the general approach. Most of the marks are going for, have you identified how unwell this patient is? Have you escalated, and have you informed the relevant specialties that need to, or informed the relevant specialties that need to be involved? And then the rest of it is kind of specific management. So my own impression is that the emphasis is on the safety of the patient. And of course, there'll be marks for medical knowledge as well, so the specific management of the condition, but both are important. So you are the medical SHO on call and have been asked to go to ED and admit a stable upper GI bleed. So while you are reviewing the patient, he has an episode of large volume hematemesis. His blood pressure drops to 90/60, and his heart rate is 120. So how are you going to manage this patient?
Yeah, okay. Well, so thanks for the scenario and the question, Sarah. I think the first thing is to, because in the start it's a stable upper GI bleed. Stable upper GI bleed are dealt not as serious as an unstable GI bleed. But I think I was lucky when I went there and the patient started to become unstable in front of me. So I was just there. I did not lose any time. So the first and most important thing is a medical SHO. I think this patient, if it's an A&E, it has to be brought to the resus room. So the environment is very important, where you have all the resources and equipment. And if it's not in the resus room, it should be transferred to the resus room immediately. And again, this is a case where you will need 1 or 2 persons around you. If you have your registrar easy, that depending who you are on the team with, then you can ask them to help you with this case. But I think the most easy scenario, I think most commonly what happens is the ED reg or ED nurses or resus nurses will straight away run and come to you and help you with this. So the next step would be to make sure the patient has a proper access, intravenous access. And a quick review of previous history: is this patient has a liver disease or not? So in any GI bleed, the liver disease is a very, very important part, because the liver disease patient will not do well, and they will get worse and worse in front of you, as compared to a peptic ulcer bleed. So a peptic ulcer bleed can be serious, but it improves really quickly, so the treatment response is quick. So, I mean, the first thing is a proper place. So in ED, it should be brought to resus. The nurses in resus and the ED reg should be called to help get a wide bore access on both sides, and cross match for 4 units straight away, O negative blood, and start with IV fluids. So, and then if it's you all will be astonished now. I'm going to technical guidelines here on the GI bleed, that no PPI should be used in such case. Okay, so the guideline says no PPI. I mean, everybody thinks that it's just foolish. Every single patient is on PPI when you go there. So it's just, I don't know. Some people dispute the guidelines. Some people say you're not losing anything, so PPI is not going to do any harm. So do it. Okay, so so wide bore access resuscitation is the key here, and then cross-match check coagulopathy, INR platelets, PTA, PTT, and try and correct them, and fibrinogen levels if it's a liver disease. Platelets, if it's low, obviously in cirrhotics, platelets can be low. So all these blood products needs to be started, and in endoscopy, well, before you call for endoscopy, it has to be stabilized. The blood pressure and heart rate should be in certain range to be for patient to be scoped. Very rarely patients are scoped overnight. They can be easily scoped 9 to 5 if they're stabilized. And then you call for your seniors, I mean your gastro registrar or a consultant to help with this case. Start antibiotics. Broad spectrum antibiotics is a backbone in any upper GI bleed as well. So like we start normally tazocine, but any broad spectrum antibiotic will be important. Then depends what exactly, like on the history, was it medication related, NSAIDs intake or abuse, or is it liver disease? The management slowly goes towards that side then. So I think as SHO, a general medical SHO, I mean, there's no such as a gastroenterology specialty SHO. Make sure the first 3-4 points are covered. The patient is brought into resus or high dependency unit, and you have people that can access wide bore cannula, and you should ask for help in timely manner if there's nobody around you or you're on your own, and at least start red blood cell to start immediately in an
Very
upper,
good, yeah.
in an unstable bleed, yeah.
Exactly. And I think one thing they also look for as well, and of course you're a consultant gastroenterologist, so you're well able to manage these situations yourself. And for a medical SHO, they want to hear that the medical reg has been informed and involved, and the surgical reg has been informed and involved as well. And we might touch upon this a little bit later, because another common scenario is that the surgeons are refusing to see a patient, and how would you approach that? But that's more in the ethical side. So we might just touch that later.
Yeah, it's a geographical issue there a little bit, because geographical issue is because in the GI bleed specifically, in Ireland, it's stable and unstable GI bleed. And unstable bleed goes to surgeons, and a stable GI bleed goes to gastroenterologists or medical team. But if you take NHS, every upper GI bleed, even if it's stable or unstable, goes to gastroenterologists. Because the most common unstable bleed is a varicose bleed, and the surgeons cannot treat that. and the prognosis and the outcome was bad when they were admitted under surgeons. No disrespect to surgeons if we have surgeons here, but I mean, the variceal bleed is a totally different ballgame. It's not. So upper GI bleed goes to medicine, and lower GI bleed goes to surgeons in the UK. But in Ireland, it's the stable and unstable. And I have rarely come across a case where the both agreed that this is stable and both agreed that this is not stable. So the surgeon says it's stable, and the physician says it's unstable. So it's always a bit tricky. Mustafa, you triage them and you know better.
Yeah, it is the story of my life, stable, unstable. What is stable? What is unstable? I think we stick to the interview part, because what Sarah is saying, again, we can talk so much about upper GI and lower GI bleeds and what is stable and who scopes and who should have access. But I think we're going to move on to the ethical side of it, as in an interview, what we need to come across. Sarah,
Yes, absolutely. We could talk for days about this.
But I think at basic SHO level, the basic points are there. I think the surgeon's medicine is coming after it. But I think if your reg comes or senior comes, the SHO has done few bits and pieces which are appropriate. That's all.
Absolutely, absolutely. That's exactly what they want to hear, that you move the patient to resus, you've involved the ED team if they're there, and you secure access and organize blood. Great. Okay, so next, I'm going to approach a question that Lucy was asked, where you're the cardiology SHO, or you're the cardiology SHO in a cardiology clinic, and you have a patient in their mid-50s to 60s, a family history of ischemic heart disease, a personal history of ischemic heart disease, and they report to you that they very casually have had a syncopal episode on their way in to see you. So I'm going to ask a consultant cardiologist, Dr. Sajjad, to please give his a response to this question. And the reason I'm focusing on this question is because it has come up year and year, again and again, time and time again. So, Dr. Sajjad, whenever you're ready, if you could tell us how you would like this question to be answered.
Yeah, thanks, Sarah. Thanks, everybody, for joining us. Essentially, I think where I am is from the point of view of SHO's interviews, all they want to know is, one, you have worked in your head few things. One, the safety of the patient is paramount. So you can't second that. So you have to make sure that they're safe. And then the usual scenario, all of us have been saying to you, everybody, for SHO, it's A, B, C, D, E to start with, especially if they've collapsed, the disability part is there, that you have to make sure that they've not injured themselves, just put them in a safe kind of a stretcher or something, that they don't collapse on you while they're sitting in front of you. And then you work out your common differential diagnoses. That's for every scenario that you get. You have to just think in your head, what's the most likely differential diagnosis is here. And if there are 6, if you got 3 of them, that's more than enough. If you got 2 of them, you just work through them and just tell them what you're going to do. So in this kind of patient who has got ischemic heart disease and he's collapsed, you're still working on either its ischemic origin, either it's arrhythmic origin, then there's a decompensatory origin. Then these patients can also get, because they're on medications or their LV function isn't the best, they get orthostatic origin of these kind of collapses. So these kind of scenarios, you work through it. And then obviously there's non-cardiac causes. So what they want you to do is, one, to just go through ABCD. Their breathing is fine, their airway is good, their circulation, you check their blood pressure, you make sure they've not hurt themselves on their last fall, and then you just work through them. You get an ECG done, you get their cardiac monitoring done, you get your blood pressure done, and then build it up from there. You involve your seniors, you're in a clinic scenarios, there's always registrars, there's always current consultants there. And usually these kind of patients, if there's anything found on the ECGs, if there's a follow-up question on it, they give you an ECG, for example, which is rarely done. You can build it up from there. If it's an MI, you bring them to cardiology ward, CCU, cath lab, what's your usual port of call. Most of the hospitals now in Ireland, they would activate if it is daytime and the clinic is happening, and if there's an ischemic origin on the ECG or a ST elevation kind of thing, they would activate the cath labs. That's what you usually bring you to. Or if it's not, if there's an arrhythmic origin, then you tell them that I would bring him to resus or somewhere. But again, the basic line is, one, safety for us. Whenever we have interviewed for an SHO level, nobody is as Raheem said, expecting heroics. All we have to do is make sure that there is no safety concerns. So just make sure you involve your seniors, you bring them to the appropriate environment, you look after them. And during that, while you're saying that, you mention A, B, C, D, E, and you also mention what differential diagnosis you've made in your head and try and work around it. That's what I would approach this.
Mm-hmm. And one thing because I got this question, so I remember in the interview, I tried to get a history, and they actually don't give you that much information. So what they want is they want to know what your differentials are and what might make you think about one over the other. But then to focus on how you're going to differentiate and come to the correct diagnosis and how you're going to match. So it's, again, it's a very general approach that they want to see, because I tried very hard to ask questions
Get some answers out.
and give them a diagnosis, not a differential. But that's not what they were looking for. They weren't looking for a diagnosis. They wanted differentials, and they wanted general management and the list of exactly environment, and then to go from there. Great. So I think I'll ask you as well, Dr. Sajat, to tell us how you would approach this question on audits and research. I think it makes a lot of interviewees very nervous. Most people maybe at this stage haven't done huge amounts of research, or they're only starting in the world of research and audit, and as a result don't know how to approach this question, don't know how to answer this question. Everyone has done something at some level, and I think it's important to take ownership of what you have done and be confident in what you have done. Know it very well, of course, inside out, and be able to speak about it. So I'm going to ask you again a general question as to how you would differentiate between a good response and a poor response when addressing this question.
Yeah, no, as earlier speakers have said, be always prepared. If you've mentioned anything in your CV about research, you should know it inside out, and you should have practiced verbalizing it at least 10 times, if not more. Just because if you have put it in your CV and then you're asked about it and you don't know the ins and outs of it, you definitely have caused a problem for yourself. Big thing is, as we come to, most of us who have come from Pakistan, they wouldn't have done the internship here, so you would have done an SHO job. So even if you haven't done a proper audit, if you've mentioned something, you have to prepare it. Or if you don't have it, when they ask you, you can kind of, if you have, since you put in your application and got involved in a project, you can highlight it. You're not sure if you would get marks towards it, because where it is usually you have to have kind of some work done. And for audits, where it is the big thing is you have to have a full audit cycle, and then a re-audit kind of thing planned out for it when you're talking about it. And if you have put it in your CV, you have to have a full audit cycle, then a re-audit kind of thing around the same thing. That's for audit. And if you have research, again, the big thing is know it inside out. You should have it on your tip of your tongue. So if you're asked any follow-up questions on it, you shouldn't be thinking around it. You have the ownership of that research. So if you have it properly, you should know that topic inside out, is my take on it.
Mm-hmm. And I think this question is asked differently sometimes. So sometimes the question is, tell us what you understand about an audit and an audit cycle. So they're asking you for definitions, and other times they just go ahead and ask you, tell us about an audit that you've done. But I think the answer is the same in both circumstances, where they want you to define an audit or an audit cycle to demonstrate understanding, and then not stop there, even though that's the question they've asked, but to continue and to say, I demonstrated this when I performed an audit with my respiratory department over COVID. And you need to have something to speak about. I think everyone sitting in a BST interview needs to have an audit done at some point recently enough to speak about. So even, I mean, perhaps from today it's a bit late because the interview is only starting next week, but even at the time, if you don't have something done at the time of your application, or even your shortlisting for interview, there's time there even to think of something, sit down with your seniors, get a project together, and so that you can say to them that I have not completed my audit cycle yet, but this is what I'm doing and this is how I will complete it. So there's no way you can go into the BST interview, in my opinion, without having an answer to this question and an audit completed or in progress, because having one in progress would be better than having nothing.
Indeed, and they always kind of ask you what the plans around it, or what do you understand around it. So have something in your in your kind of preparation that you can talk about and kind of give the answer. You can't just turn around, because as Samreen went through it, there's marks around it. So even if you don't get the full marks, at least if you understand about it, they might give you something on it. And it's, again, ultimately, it's the verbalization that you do. It's how you come across to your interview that they ultimately decide about taking you or not taking you.
Absolutely, definitely. And same with research. If you're asked about research, you can talk about your audits if that's what you've done. If you've separate research, you can start off by saying or talking about why you think research is important, and then go ahead and speak about your research, and vice versa. If they ask you, the question they ask you is why is research important, you answer that, and then go ahead and speak about any research projects you've done. So again, I don't think this is one we'll spend more time on, because I think everyone should have an answer prepared for this. And again, something in progress is better than speaking about nothing if you haven't anything done. Okay, good. Thanks very much, Dr. Sajjad. What we're going to do next is move on to the ethical scenarios. So Dr. Usman, who is also a rheumatology fellow, completed their SPR training in rheumatology, is going to speak about their general approach to ethical scenarios, and specifically we're going to focus on capacity assessment, where a patient is attempting discharge against medical advice or refusing treatment, and a difficult colleague or colleagues. So Usman, whenever you're ready, if you could join us.
Hey,
And let us know how
can anyone hear me all right? I think there was some
Yep, we can
problem
hear you
with the
okay.
microphone.
Yeah, we can hear you perfectly fine.
You hearing me all right?
All is well, Usman. The floor is all yours.
Okay. So welcome everyone. So Sarah has given me task to engage an audience at 10 o'clock on Saturday night. I'll do my best. It's an ethical scenario which no one really wants to deal with, but basically, I mean, I know ethical questions are difficult to answer, and it's not just at SHO level. I think every level you take the interview, whether it's SP or a consultant, ethical question can always be a bit challenging. The reason is that there is possibly not an ideal solution to the ethical scenario you are presented with. So just when you are answering that question, just keep that in mind, that they're not looking for you to find an ideal solution to that scenario, because there might not be any ideal solution. What they all want, all they need to see is that as an SHO, you know the process and you know what steps you need to do as a part of your responsibility as a medical SHO. So I'll just talk about capacity, because capacity is important, and to understand, to answer this question, I think capacity would be an important idea to familiarize yourself with. So basically, a patient is said to have capacity if they understand what the information is provided to them. They're able to retain that information. They're able to weigh that information with all the possible risk and benefit. And then using all that, they're able to give you their informed decision. So in a simple word, if you're telling patient something, as long as patient understand that, they understand the risk benefit, and they're able to take their decision on the basis of that, they are said to have capacity. Someone taking a decision against the medical advice, or someone is not listening to your advice, does not mean that they have capacity. It just means that they are not agreeing with your decision, or they're not going what you are telling them to. But as long as they have capacity, legally they have right to kind of take that decision. As a doctor, it is our responsibility to kind of tell them about all the possible risk benefit associated with as a result of their decision, but you cannot enforce your decision onto them. Another thing in these ethical scenario, which is just linked with capacity, is to go through principle of ethics. I won't go through all of them because it will take a lot of time, but as a general rule, as medical professional, some of the ethics that we follow is to make sure whatever we do is in patient's best interest, do not do any harm to the patient. One of that pillar is also patient's autonomy, which means that patient have absolutely all the right to decide what they want for themselves and what they choose. So that term is important for you to know, because because it kind of shows that you know what right patient has. So again, all these scenarios can be asked in different way, and there won't be a same answer to all the possible scenarios. But if you just kind of follow a few principles um, to answer that, that will be good enough for SHO level. Like, I mean, I'll just go through an example very quickly, and I'll tell you how I would approach that scenario. Like, I mean, if you're asked that you have been referred a patient by ED who came in with a chest pain with some T-wave inversions, who needs a medical admission for workup, and now the patient wants to go home, and how would you approach that issue? So the way I would answer is that I will tell the interviewer that I'll first make sure the patient has capacity to take the decision. And the way I do is that I'll go and talk to the patient. I'll explain to them the reason for them being admitted is the chest pain. They need further workup, possible blood test, uh, cardiac investigation the next day. And I'll make sure the patient understand all that information. I'll also explain to the patient the benefit of getting all that to make sure that they don't have any coronary artery disease. And if they do, they get the appropriate treatment. And the risk of them going home without getting all that would be possible worsening of the situation and them getting more unwell and even death. I'll make sure the patient understand that information. And if the patient fully understand the risk they are taking by going home and still wants to go home, that is patient's autonomy. And and they want to sign against medical advice, I cannot force them to stay. So this would be an answer to cover the basic aspects, and you are kind of covered legally from till to answer up till that. But to stand out in the interview, there's always few more things that you can add to your answer, just to let the examiner know that you're not going through the answer that is mentioned in all the interview book. There, you're thinking in your mind what else you can do. So you should always mention that I'll talk with the patient. I'll try to find the reason for them not wanting to stay in the hospital. Sometimes the reason could be very, very simple. They might be sitting in ED for 10 hours and they are tired. They don't know when they are getting the bed. And just by talking to them and saying to them that you'll find out when they will getting the place in the ward, that is all what they might need. You know, sometime a listening ear is what the patient need. An important thing is not to say that you will make false promises. That's the worst thing you can do in an interview, that I'll tell the patient I'll find the bed. That is not your place to promise bed to anyone. You should know your limits. So you definitely should say that I will ask, and if the patient is angry about the bed, I will tell them that I'll go and talk to the bed manager, but I cannot promise them that they'll get a bed. This is what they want to hear. They don't want you to come out as a hero saying that I saved the situation and the patient is staying because. So that is what not happen. That is what not is an ideal answer. If doing that still patient wants to go home, you should always mention that you'll try to talk to next of kin. You try to talk to relatives with patient permission, obviously, to see if there's anything you can do to try and convince them to stay. Another thing, always mention in this scenario that you escalate this to your senior member of the team. They want to know that you're a safe doctor and you know your limitation. But don't start your answer saying that you'll talk to your consultant. That should not be your first point in your answer. That should be the third or fourth point after you have done what is expected of you, what is expected from you as an SHO. So escalate to the Reg. The reason being, Reg would have more experience than you. He would have came across this situation in the past and might have a better way to deal with that. And lastly, you also should kind of say to the examiner that just to show that you are a safe doctor and you think about the patient, that if despite doing all that patient still wants to go home, you'll make sure that you can do whatever to ensure patient safety, that make sure they go home with their relative, there's someone at home, tell them all the red flags, make sure you make it clear to the patient they can come back to the hospital whenever they want, and always say that you try to make a follow-up appointment for this patient, whether it's medical assessment unit or a clinic. So obviously you won't be asked a scenario like this, but generally the scenario would be like this. So as long as you discuss that the capacity is something you look, patient safety is something you look, you respect patient autonomy, you know your limitation. And if you are in a situation where nothing is working, you will do whatever to ensure that patient is going home in some safe scenario and there is some follow-up plan. So if you answer your question on these pattern, I think it should be well received.
Absolutely, I would agree with everything you said there, Usman. So there are two things that really stood out to me, and the first one was that your first response should not be to escalate to the consultant on call, because I would agree that that's of course a very important part of your answer, or to escalate to a senior on call, but it shouldn't be your first response. It's something that you would do later on after you've tried some methods yourself to de-escalate the situation, or to manage the situation, or even to identify what's going on and address it as well as you can. And the other important thing was a follow-up. So I think we've gotten into this terrible habit of, if someone's a DAMA or if someone's discharged against medical advice, they don't get discharge letters, they don't get prescriptions, and no follow-up is arranged for them typically. So we've gotten into the terrible habit of doing that to patients that discharge against medical advice, and it's very important to not say that in your answer, also not do that in practice, but to arrange follow-up. And so for this patient who is potentially having an acute coronary event or other issues with the heart, would need follow-up in some shape of form. And again, if they refuse a follow-up that they are agreeable to is important as well. If they refuse hospital follow-up, then to make sure that they have GP follow-up or some sort of follow-up. So there are two things that I think stood out to me in particular. And there are so many ethical scenarios, it's impossible to know every single one of them inside out. And of course, the answer does vary depending on the specific scenario, but it's just not possible to prepare an answer for each one. So again, I would focus on general principles, general approach, and I would mention all of this in my answer, that, oh, well, this is a difficult situation. I'll give yourself a couple of minutes. I think the ethical scenarios, even in the MRCPI exams, they're there to catch you out, actually. And they're sometimes designed for you to fall in certain traps. So take a minute, thank them for the question if you need to, maybe ask them to clarify parts of the question if needed, and in that time formulate a response, think about a response. If you've again practiced this, you've practiced speaking about the principles of medical ethics, and it will come to you a lot more quickly and easily, and there'll be more fluency in your answer. But it's impossible to prepare every single scenario. So again, focus on general approach and the common questions that come up. So capacity is one that comes up quite frequently, and they're not going to sit down and ask you how do you approach assessing patient capacity. The question is going to be that's going to be hidden in the question, and they might say that a patient is refusing treatment, or like Lucy mentioned earlier, her scenario was that there's a patient with a stable upper GI bleed who does not wish to have an OGD, or does not wish to stay for an inpatient OGD. So that is a capacity assessment and safety netting as well. So to identify what the question is asking, and then to go from there. But again, I would focus more on general approach, and then just the common ethical scenarios that come up, I would have answers ready to go. Great, so I'm going to jump back to Dr. Khan just for the last ethical scenario I want to touch on, and this is the reason I'm asking this one in particular is because I was approached by someone who's at the BST last year, and I think they might have struggled a little bit with this question, so I said we'll focus on it just briefly to hit on some certain principles. So the scenario, Dr. Rahim Khan, I'm going to ask you is, you have a patient with HIV who has refused to disclose their status to their partner, and how you would manage this. If you don't mind, just very briefly, maybe telling us what the important points to mention would be.
Okay. Thanks, Sarah. So I think Usman did a very good point on capacity assessment. I'll come to my scenario shortly now. The one most important thing is, I think, the level of your, like an SHO, I think documentation is important. I think there should be a mention of documentation in the chart, what an SHO has written and what steps has been done. The other most important thing is when the patient, for example, the decision is he's going home, the safety netting is very, very important. I mean, some good SHOs I've seen they have done a discharge letter and made a phone call to the GP, to be honest, to say this patient presented here and he left against medical advice. We're just informing you, if he comes to you with chest pain, we have given him some tablets, even though he refused cath lab, for example, you know, or he refused endoscopy, you give PPI, whatever. So give them the prescription for treatment, or if it's a sepsis, give antibiotic tablet, even if you think it should be IV. So give a proper prescription, inform the GP, and document it in the chart, and the consultant will see it. It will be impressive. Okay, so on my scenario, it's again, the ethical questions, as Usman alluded, was in the start, is, you know, you don't, there's no, you cannot actually solve the problem. Like, if the problem is there, but you need to follow the process the right way to handle it. That's the basic thing. So the right way to process it. So we have a patient in the clinic who has been diagnosed with HIV, and you know, it's a duty of care for you to inform his partner. So how are you going to approach that? And the patient is refusing and not agreeing that you should not inform his partner because it can cause problem. And so, I mean, the main focus on this scenario is that I think in our own, like in every specialty, there's cases that are functional. We deal with a lot of irritable bowel syndrome patients. I think the things that will make difference is empathy, listen to the patient, give them the time, and it might be a new diagnosis and a shock to them, and express that you're concerned and you genuinely wants to help him, and give him the treatment. So, I mean, the main point that then after that you're coming to is to persuade the patient to inform his partner himself, to do it in his own way. So you're not just picking up phone call or, you know, telling his partner, but you're trying to convince the patient to inform the partner who is in close sexual contact. I think the first important part is to ascertain what kind of sexual, like in this particular scenario, is he's practicing safe sex, or is it risky, or it's you know, is there any use of any like protective devices that there's a less risk of infection. Once you ascertain this, then you can probably imagine the risk of transmission may be high. And then you can use some specific areas where you can focus on to say, this is all about to persuade him to do it himself rather than you. So you can say, look, if he has children or his wife or whatever, you can say, if we inform her, or if she is informed, she can be tested and treated in time. If it's delayed, she can run into real bad complications. You have a young family, and we need to sort this out in time rather than sooner than later, you know. So if we keep this hiding, it will have consequences in terms of social and also medical consequences. Social are, if you, for example, you inform your partner after 2 years and she's very advanced into HIV, she has contracted and sick, it will end up in, for example, he thinks that my marriage will end, I will be divorced if I tell my wife about HIV. But you can tell that I think it's important to tell, because it will save your marriage if you tell now rather than after a year. So if you tell your wife after a year, it will be more anger and more bad consequences rather than now. So I think it's better. And then also she can get a timely treatment. If she might be already positive, she might have it. You know, she might have it. So it's important. So all these conversations are in an important way. You're not giving a shock to a patient to say, now I have diagnosed you, and I'm also saying that your wife also has a HIV. No, that's not true. But I think from the medical point of view, I think we need to act quickly to give her the treatment if there is, you know, rather than delaying it, and then it can result into medical consequences later on. So that way, I think most patients will agree to say, that's fine, I will go home and discuss. Now, you can offer to say that I'm happy to meet both of you together to discuss this in a very confidential way. I think some patients also will have fear that people will know and it's a, you know, it's not good for me in the society. But I think you need to reiterate again and again that I'm your treating doctor. Nobody's going to know except me and you and your partner if we're going to tell her this is going to be strictly confidential, and we will give you the treatment that is needed in a timely way, and people can spend normal life if treated in time rather than delayed. So I think some words of confidence, some words of reassurance, and taking his empathy and confidence into consideration will help. And most of the time, they end in a conversation where he agrees to say, okay, I will take 1 or 2 days. I need to think, and I will inform my partner. That will be the best outcome. But then, if still they don't agree, then the other scenario is then you're going to come across from the other end to say that it's my obligation. I'm legally bound. It's my obligation that we have to inform your partner, even if you disagree. So then sometimes that will, so because patients doesn't know, they just think that if I say no, it's no, so nobody can do it and the doctor can't do it. But then you're going to tell them that your level of for example, legally you're not protected if you don't tell his partner. You have to inform him, and it's a harm to another person in the society. So that way, that scenario, I think if you cover that part, it should work out for you. But I think the most important thing is taking time. It may take longer than your normal clinic consultation with a patient, but this is what you should be doing. And if they at the end disagree, you have to inform the partner in a very confidential way, regardless. So if the interviewer insists and insists, some interviewer will insist to say no. He said he's still saying no, so no means no. So then you're going to say, okay, well, we have to inform your partner whether you agree or disagree, because this is my duty of care. But the appropriate will be, if it comes from you, it will be most appropriate rather than us. So it's that kind of scenario.
Absolutely. No, I think that's the main thing, that you don't just say, oh, I would try my best to have the patient disclose this, but if they don't, I'm going to have to disclose it. I think the answer is a lot more detailed, and I think you gave a very, very, very good response there in all the different ways you will try and identify what is the main issue or main thing stopping or preventing the patient from disclosing this, and how all the different ways you're going to try and address those issues to get the patient to disclose it themselves. So that was very good. And I might ask Dr. Anwar as well if he's there to add anything if you'd like to, and also to maybe give us some closing remarks and or general messages that he may have for anyone doing their interview in the next coming weeks.
Thanks very much, Sarah, and thank you everyone for being the part of this process and this initiative by IPA. I think what I'm delighted about is that the talks that we have heard so far, they are so complementary, although it was not pre-planned to be so, but somehow it has happened that everybody has chipped in and they have focused on a different aspect. I think, in my opinion, especially being the interviewer for BST candidate, as Samreen has expressed, it's a very structured process. First of all, the candidates must know it's a structured process, and the interview is a part of it. As she said, there are 3 components to it, and the interview is going to be one of them. The questions are very structured, for example. It's not up to the interviewer to ask whatever they want. So the questions and the standard answers are available, and they're given to the interviewers just before the interview starts. So everyone who goes to a group of interviewers will have same questions asked. What I felt is that it is a very short time span, as Lucy has alluded to as well. So what I feel is that all the speakers have given us very elaborative overview of the things, but what the interviewer would want is for you to summarize those things. For example, if you have a patient like Dr. Sajjad mentioned, gave him a scenario. I think the first thing what the interviewee should say is what they think it is wrong. For example, saying that this patient seems to have a syncopal episode. That is kind of a buzzword, for example, and that will make the interviewer understand that you are following and you have an understanding and know what exactly is going on. Similarly, for example, the scenario you gave to Rahim Shah, patient has GI bleed, and what happened is that blood pressure dropped. If we start by saying that this patient has developed a hemorrhagic shock, when you say that word, the interviewers are very impressed by that. Like I was very impressed, because then the person can say, I will start the I will start the hemorrhagic, shock protocol. Similarly, somebody has chest pain and their troponin is high. You will say this is a non-STEMI, and I will start the protocol, and then you can explain the protocol. The time is short, so you don't have a lot of time. The second thing, which you alluded to as well, is that sometimes the ethical questions are hidden in a clinical scenario. So you need to, first of all, be able to identify that this question is not focusing on the clinical scenario, but behind that, they want to know what exactly is the capacity, for example, the GI bleed and the capacity. So it's not about the management of GI bleed, it's about the patient. One of the topic which I think everyone should address is this assisted decision making, which is relatively new in Ireland. And I found it quite complicated, and so did the solicitors that I came across with. There is an excellent presentation on the HSE land, and I would suggest to all doctors, regardless of their interview or not going for interview, even for consultants and registrars alike, it's extremely beneficial. And my understanding of this whole thing completely changed when I did this. When I listened to this presentation. So I think first thing people need to know that they have sent the CV and they have sent the application that has already been marked. So the interviewers are told that we don't have to talk about the CV or their background. We straight on kickstart with the questions. As Lucy has said, it's an abrupt kind of a process, a little introduction, straight on to questions. And the CV has been dealt with. The person from the RCPI tells us that, look, they have marked people already. One of the disadvantage with people from abroad had last time when we were interviewing is that they did not have a transcript from their medical school, because this is not something usual that they get. So I would suggest to all the people who do not have a transcript, they should have a letter or something to show what percentile in the class they were on, because they were given extra marks for that. So I think the questions are human. There is a huge number of questions that can be asked. Any clinical scenario, be it GI bleed, syncope. But I think, as everybody has said, back to basics. You think that you are in ED, you are presented with this patient, and just say what you would do in your normal situation, but be precise. Try to give them a unifying diagnosis to begin with, and then other possibilities. Because once you have a unifying primary diagnosis, you can have a workup according to that. And if it's not very clear, then of course, and there's a differential diagnosis rather than a particular primary diagnosis, then of course you can suggest other tests. So I think it's just, again, as people have said, practice. And this idea of using a camera is very good. Actually, I paid a lot of money when I went for a course for my SPR interview, and all they did was put a camera in front of me and recorded me and then showed it to me, and I could critique myself. So I didn't need anybody else's critique. So I think what Rahim has said is very, very relevant. But I think it has been very comprehensive from everyone's point of view. People who are listening, they must be feeling that they're fortunate to have all that advice. All they need to do is just make it more precise and concise. But certain basic things, they should all read the medical council book, okay? Because these questions are based on the standards of care, and they are based on the legality, as we said, about capacity and about HIV. What is our primary responsibility is to save other people from harm. So if you have HIV, if you have a seizure and you're not complying, we have to inform other people. So like your bus driver, for example. So that's what I would say. But if there are any questions, I'm happy to answer. But one question I would address, there was a question in the chat box. Somebody said that if they have worked in psychiatry, would that help for medical BST? I think it's not just what you do, it's about your attitude as well. For example, one of the interviewees had worked in orthopedics. I recently interviewed an SHO. She was actually one of the participants in this webinar. And she worked in orthopedics. And while her stay in 6 months, she had done an excellent project. So that just shows your attitude that wherever you are, whatever opportunity is presented to you, just you take it on. You're not just a passive person who is waiting for some opportunity. You just grab every opportunity which is presented to you, and that tells you about the future trend a person will take. So I think wherever you are, whatever you're doing, make best use of your time and the opportunities that you're presented with. It does not matter the specialty, because eventually, if you are good at doing something, most likely you're going to be good at doing another specialty as well. It's more about attitudes and your behavior, as well as your clinical knowledge and the acumen and the experience. Thank you.
Thank you very much, Dr. Anwar. So Dr. Anwar's advice is invaluable. He sits on the BST panel and interviews for numerous different positions. So thank you very much for your time and going through that. I'm going to echo the same, that you have to practice. I wrote down answers to all the common questions and take every opportunity to sit down and look at myself in the mirror answering these questions, videotape myself answering these questions, and then play it back. And the more you say things out loud, the more quickly they'll come to you in the actual interview as well. And again, the fluency will be there. So that's really, really important practice. Doesn't always make perfect, but sometimes can. And if you fail to prepare to fail. So I think that's very true for interviews. So what I might do is I'm going to thank all of my panelists. Thank you all so much for joining us at such short notice as well in some cases. I think this has been very brilliant, and the advice given has been, again, invaluable. I'm going to move now to Mustafa and ask him to moderate the Q&A, because he's been keeping an eye on the questions coming in. There's some repetitive questions, so Mustafa, if you just want to go through some of the important ones.
Thank you, sir, and thanks to all the panelists. It was amazing. Even for me, it was such a refreshing session, listening to all the physician colleagues of mine. So the Q&A session, so there are a lot of questions regarding around ethics. So there's a question that your consultant has discharged a patient who you are not confident and think should have stayed as he was not stable. How will you approach this? Does anyone want to take it from the panel?
Can I say something?
Yes.
So the way I look at these things is that whatever decision you make during your ward rounds are conditional, and they're based on the situation at hand. Things can change. And I actually tell my team all the time that if you disagree with me, tell me. If you find something new later on, you have to. So it's not about your egos that you have made a decision and nobody can revert it. So I would say that if I am an SHO and I have any concerns in my head, I would go back to the person who discharged. If it's a registrar, go to registrar and very politely, nicely show and share my concern and tell them why and try to convince them. And I think there's no reason that anybody who is there, they would not review their decision. So I think it's not just you are a qualified physician yourself, and your opinion matters, no matter how junior you are. And a lot of time what I've seen, and I learned from myself, that I was an SHO and my professor was actually a very, very highly acclaimed gastroenterologist. And I gave an opinion, and he actually, surprisingly to me, followed that opinion and got a CT angiogram because I felt that this patient might have abdominal angina, like superior mesenteric artery stenosis. So I think there's no harm, and there's no reason for us as an SHO not to share our concerns. This is the way we learn. And anyone can make a mistake, or there can be an oversight, and person might have made a decision based on some misinformation. So I think the patient safety is first and foremost. Therefore, you must go back to your consultant and tell them what your concerns are, and then review that decision again.
Perfect. That's absolutely what it's all about. That you need to raise your concern in a reasonable manner. So you're not going to go right in the middle of the ward round and disrupt everything and say, "Oh, you are wrong," and I think you've done a wrong decision. That's now you're going to take it. You're going to go in and speak to your consultant. Usman, you want to come on that?
Yeah. So basically, there are a couple of ways to answer this question, and whenever I went for the interview, there's a good mnemonic to remember, because obviously this is a very difficult scenario, and the interview panel can put you in a difficult situation if you either show yourself as being too heroic or being too intimidated by the consultant. So you cannot go to either extreme. So SPIES is the mnemonic that you can find in most of these answers for these scenarios. So it's the first is seek more information, second is patient safety, third is initiative, four is escalate, and five is support. So I mean, you can modify your answer according to the situation, but let's, for the sake of example, if this is the question, if the consultant have discharged a patient that you feel is not ready, so the first thing, obviously, you also need to keep in mind that you need to keep the hierarchy in mind. You cannot be kind of starting questioning your consultant in the ward round. So the first is to seek more information. The consultant might have made a follow-up plan. If the patient is IV antibiotic, consultant might have made a plan to have it done in the community. If the patient is not safe, but the patient wanted to go home, consultant might have assessed the capacity, and he is doing what he is obliged to legally. So seek more information should be your first step to get to know more, not just that you have this feeling. Then obviously, if you have seeked the information and you feel that there was not absolutely nothing for the patient, then second is patient safety. So you need to ensure the patient safety. If the patient is an immediate threat, if you feel the patient going home will cause harm to the patient, then you need to approach your consultant, like Dr. Anwar and Dr. Mustafa said, that you need to approach your consultant in a respectable manner, and to not to cause any embarrassment or drama, but you just to get your opinion out there, that I feel, looking at this patient, which I've met a couple of days ago, the patient is not back to normal, things like that. I won't go into too much detail. Then you should also mention that you should escalate the situation if you're not able to sort it on your level, which means that if the consultant is adamant, not listening to anyone advice, and patient is in immediate danger, what they want to hear you say that you either talk to a more senior consultant from a different team or escalate it to clinical director, keeping patient safety in mind. And then last is you can offer support, that if consultant is feeling that there's too much burden in the ward and the patient can go home on the weekend, you offer to come on the weekend and discharge the patient. So in all those scenarios, you might not be able to go through all these points, but SPIES is the mnemonic. If you keep in mind, you kind of go through few of them, you should be able to answer most of the scenarios.
Thank you, Usman. That mnemonic is really good because when you're in an exam situation, interview situation, adrenaline kicks in and you forget a lot of things that you were prepared for. But mnemonic is something that kick in very quickly, and you've got a structure to your questions and answers. I think that's amazing. Another question is about a patient who has had GI bleed but is taking antiplatelets. How would you counsel the patient as a medical SHO? Tala, I'm not entirely sure what you want to ask here. Considering the risk benefit, how would you respond and how would you counsel the patient as a medical SHO? That's the question. Rahim, being a gastroenterologist, and Malik Saab being a gastroenterologist, I would bounce it off you.
I think.
Not sure what the question is about. I think it is about counseling.
Yeah, the question is not very clear, but maybe it might be a little bit of a pharmacological interaction he's alluding to say he was given antiplatelets along with SSRIs, which can interact and cause GI bleed. So some other doctor has made a mistake combining the two medications, and it has resulted in a GI bleed. I think that's all I can make out from this scenario. So in this case, basically what it is, I think Talha is asking, someone else has made a mistake. Now the patient is in trouble. How are you going to deal with that scenario? So I think it's again an ethical part. So you're going to, the first thing is obviously ABC, you're managing, you make sure your patient is safety and the patient is treated. When it's all settled, you're going to hold whatever medication is causing this or interacting with this. Like if he's on antiplatelets for example, a serious, he had a PCI or he had, a serious cardiac event, then you need to discuss with a cardiologist. So, I mean, medical management comes first. You need to save the patient first. The second is later on when the patient is stable and assessed, we have a duty of disclosure. You can tell them that, look, well, depending on the diagnosis, it may not be totally related to antiplatelets and SSRI. Like, I mean, if it's a liver disease, he was drinking and he came with antiplatelets, SSRI. So it's a mixture of, so it will be really difficult to put it down just to these two that it caused an unstable GI bleed. But, you know, the other causes should be ruled out and it may not be related. In that case, you're not doing anything to discuss the two interactions or two problems that was caused by another doctor. But if it comes to like a drug mistake done or any mistake done by another doctor, you're going to explain, and open disclosure should be done to patient to say, look, this was done wrongly and we do apologize and we have corrected this and this has not resulted in any serious harm or death or anything. However, this was the mistake and it's our duty of disclosure. We are not blaming other people. Make sure you don't put a blame to other doctors to say they did this mistake. So then again, I don't know, there's more to this. Question is about counseling about the risk profile of drug and possible risk of in the future of antiplatelet stop considering GI bleed risk once he's discharged actually.
Yeah,
Okay,
so I
so
might add
this is
to
a
that
different, we're
actually.
going to a different direction now
Yes,
on this question.
exactly.
You know, so Talha, I think I think the point is, I mean, this we in a GI bleed with anticoagulation and antiplatelets, there's a cardiologist involved. So a simple question to answer is this: we always consult a cardiologist with antiplatelets if there's a serious GI bleed secondary to that. So I mean, you need a consult from a cardiologist to say, is it safe to stop this or not, or you know, and then the scenario is quite simple practically. If you come to this, it's not as difficult the way it sounds, you know, so it's manageable.
Sarah, do you want
Yes,
to
I
come
think.
on?
Sarah, you want to, or
Yes, I
sorry,
was just
Mustafa, you
saying.
want
So
to?
I just read that again. So I think there's huge gaps in information missing from this scenario, and I think that's if this is a question they ask you in the interview, they want you to gather more information because you don't know why this patient is on an antiplatelet. We don't know why they're on an SSRI. Are either or
Yeah,
both
yeah.
prescribed appropriately even to begin with. So there is a potential interaction, or not an interaction, but SSRIs and antiplatelets. I think there are some small studies that suggest that they may increase the risk of GI bleeding, but I think the question is more so that we don't know why they're on either drug. Do they need both drugs? Which condition is more appropriate to treat at this moment in time? And if both are required, then for the patient to know that there is a potential interaction or increase in GI bleeding. That's my understanding of that.
So I think that's the best you can answer this question. There's another question that's there, that if your colleague is absent from a call due to some emergency and you make the roster, what will you do? Anyone wants to take it? So
This is more like
Oh,
an
yeah.
administrative question rather than ethical or clinical
And an
question.
ethical, yeah.
It's more like administration. So
it's a pure admin question. You need to know your own who runs the roster. If you're making the roster, there's someone who is looking at locum, so you need to know what triggers there are. If someone is gone, obviously you need to cover the roster. So you are going to request other SHOs, someone can take the call. If not, you're going to escalate to HR, you're going to escalate to your consultant. You're going to ask HR to put out a call for locums. And you're going to see if one of the other colleagues can swap a shift today and work. So you need to work methodologically in this. That's what I do every day in emergency medicine. That
In the Irish culture, pull out from the hat, pull out names from the hat at the end, and then
I know that has
that
happened
can
in certain
easily happen
hospitals.
in some hospitals.
But you need to know. So you're going to inform your consultant first. You're going to make sure that there's no harm to the patient. So you're going to make sure that the patients that person was looking after, that someone is dedicated to see those patients. You're going to then escalate it to HR. You're going to escalate to your consultant. You're going to escalate it to your registrar that there's a person missing today. You're going to make sure that the person is okay, that the person who's gone absent, that they don't need any help or support from medical manpower or org health, that the mental health is fine, that the physical health is fine. And then obviously the triggers of HR looking for locums, triggers for trying to find a replacement locally. And that is how we're going to approach. There's no right answer to this question. The question is about How well do you know the structures within your hospital and the structures how and when certain reactions can be triggered? I hope we have answered that question. Does anyone else want to come on to it? No, that's
No, it's
okay.
fine.
I think there's one more. There's a few questions about open disclosure. So someone was given antibiotics and patient was allergic. Someone was. So remember that any mistake that is being committed in clinical settings, you've got duty of care. There is an open disclosure. You need to inform the patient that this has been done. First, you're going to manage the emergency. So if someone has had an allergic reaction, you're going to go through your ABCs. You're going to give them adrenaline. You're going to give them antihistamine, steroids, whatever needs to be done. Once the medical emergency has been managed, once whatever awkward situation has occurred has been managed, then you're going to go with your open disclosure to tell the patient, apologize in advance. Your incident report should be filed, it should be documented, and then locally you would try and formulate structures that this doesn't happen. So you're going to do an educational session, you're going to inform other SHOs, you're going to make sure a policy or a guidance to stop it from happening. Look into why it had happened at the first place and look it from happening. So these are certain. Anything else? There is one more ethical scenario. You are with two junior medical students in a cubicle, and a white guy passed a comment to a medical student with dark skin to go out of room. I don't want you here. You are an SHO. How will you deal with this scenario?
I mean, I can see Abdul Rafi has put a lot of ethical questions. Again, I mean, without answering this question specifically, I mean, I know ethical questions can worry you a lot, but like I said, this scenario, even a consultant with 20 years of experience might feel a bit challenged to solve this. Okay, so don't worry about answering it with an ideal solution. Like I said, you just need to follow the few principle that, again, safety of the patient, safety of the staff, escalating it to someone senior, and make sure kind of at the end of the day, our responsibility is the patient, but we also have responsibility to look for the well-being of our colleagues. So again, I mean, this is a scenario which I haven't come across before, but like I said, these kind of scenarios, everyone have kind of bit trouble answering that. There's no ideal
Personally, I don't
solution.
think that this scenario is going to come into a medical BST interview. It is a question for a much higher level because it
Yeah.
involves a lot of ethics. But remember, your prime. So when I go into a student with medical students, I always ask their permission first. Are you okay that these are the medical students? I'm going to perform this procedure. Are you okay with them standing there? And if a patient doesn't consent to it, they've got a right to it. You cannot force the medical students onto the patient. So remember that thing going at the back, irrespective of whether he's a racist, irrespective whether he doesn't want them because of the color of their skin, your duty of care is to the patient. Yes, then you come to the second ethical scenario that yes, it was a colored person. So how to deal with it? The support structures around this in your locally in every hospital, and you need to look through them. But I really don't think that this is a question that is going to pop up into a medical BSc interview. Um, anything? So school bus.
There's going to
with
be hundreds of ethical questions
Yeah.
that will come in the mind.
Yes, a school bus driver with sleep apnea has been told not to drive, but adamant and will continue to do so. No consultant of reg in the clinic. What will you do?
I think this question has been answered by Rahim Shah, and the principle is the same. Wherever you feel that the patient is going to be a source of harm to others, you have to activate the alarms.
Exactly.
So whether it's a seizure activity or a bus driver, if the person is only in charge of their own body, they're not in charge of their wives or other people. So I think if they are a source of harm to anybody else, then we have a duty of care. And that's why I said that we all should read the medical council ethical book, because it has all these basics covered, all these ethical principles, and we can apply them in every situation that we come across. What is the thought behind this? The thought is that cause no harm to others. You don't allow somebody, somebody is going to be harmful to others, you have to trigger the alarm.
And if you look at DVLA guidance or RSA guidance, RSA have very good guidance on a lot of medical conditions. How long do the patient have to stay off the road, and who needs to report it? Does the patient need to report it to the guards and their insurance company? There are even guidance on if someone is a cast and driving a car. So there's a lot. So please go through DVLA and RSA websites. There are lots of information about these scenarios. Rather than looking at other things, just go and visit their website. They've got a lot of scenarios on it. One last call. Is there any other questions? Because we have covered a lot of ethical scenarios. There's a question about research. So if there is a research paper on your CV, you need to know it inside out. Even if you were the 7th author and you put it on your CV, you need to know it inside out. You need to know why, where, when, how, each and everything. Otherwise, don't put it on your CV. If you don't know about it, if you haven't been a proper part of it, if someone just put your name there and you don't know anything about it, don't put it on your CV. If it is going on your CV, you need to know it inside out. One more thing is prepare for the question that you are scared of the most, the best. So the worst part of the CV, prepare it for the best. My worst part of the CV was always research, and I prepared the answer to my research question number of times. That why, and in one of my fellowship interviews, I was asked, "Oh, your CV, the research part of your CV is horrible. Have you any explanation for it?" That is how the interviewer asked me. So yes, I had prepared a proper answer to it, and I went through why it was horrible and what I'm going to do to improve it. So it's not that it's just horrible. No, I understand that this is a weakness, and these are the steps that I've taken in the past, and these are the steps that I'm going to take in the future. I think that is more. We don't have any more questions. I think we have covered all the bases. So I will, on behalf of IVP, I thank all our panelists, particularly. There was another question that I think has been answered before, just before we close it. Approach your colleague. Oh, that's an answer. Okay, that's perfect. So basically, thank you very much to all the panelists, particularly to Usman, Rahim, Dr. Sajjad, Malik Saab, Sarah. We all took time out of our weekend and we are here. I hope that the candidates have found it useful. I hope that you have learned something. I hope that you'll take it forward and hopefully implement these principles in your interview. And all the best from IPPA and all the best from all of us to all those appearing in the interview. Thank you very much.
Thank you.
Thank
Thanks,
you,
Mr.
everyone.
Thanks, everyone.
Thank you.
I would respect all the participants to please leave the meeting. Thank you.